Thank you very much, Dr. Isabel. And now the floor is open for questions. Dr. Tim, please. Can you...
Thank you for your comment. I was wondering, you told us a neuroblastoma case although we all know that it has modest specificity in neuroblastoma, in which iodine 123 MIBG may be preferable. Do you have any preference of PET-CT neuroblastoma?
Well, this is not the topic of this lecture, and in fact, as we are going to speak about bone, I am not going to speak deeply about that. But in fact, the reference tracer for neuroblastoma is MIBG, and it is available to perform MIBG labeled with iodine 123, and to perform always SPECT images of the whole body and the SPECT images of thorax and abdomen. During the at diagnosis, during the evolution, your neuroblastoma can have a high, medium or low or no uptake at all of MIBG. In cases of low uptake or no uptake, then it is advisable to perform PET with FDG. Or if during the treatment, instead of having a differentiation of the tumor becomes indifferentiate, and you have any discordance between the clinical symptoms and the MRI, the MIBG images, or you have discordances between the MRI images and the MIBG images, then it is advisable to perform a PET with FDG.
Thank you. If you allow me, I have another question for the first lecture. Which radiological imaging modality you prefer in a pregnant woman in first trimester that should be diagnosed in a bone problem?
Well, it's an immensely tricky question. Obviously, the technology, if you can do it with MRI, you should. But it is something that we see very rarely, and we discuss very intensively. Having said that, you can do bone scintigraphy if you take some precautions, but obviously MRI is preferred.
For Dr. Isabella, I want to thank you for a very informative lecture about introduction for PET-CT, especially in pediatrics. I want to ask about the autoimmune disease, especially rheumatoid, juvenile rheumatoid. What's the possibility of false positive and false negatives?
In still disease or chronic juvenile arthritis, we perform they ask for a bone scan, and then we perform a blood pool image of the whole body and bone images also of the whole body. If you can use fluorine, it's much better because the quality of the image is much better than those of the bone scan. And for the false positive, if you perform a whole body bone scan, you can detect the blood pool increased in some of the articulations, and after that you can see a diffuse increase of the bone uptake in this articulation or not. And you can detect also if after the treatment you have areas of osteonecrosis. Okay. I don't know if I answer your question.
Yes, but what the PET will add over the MRI? Especially we have the nature of these diseases, exacerbations and remissions.
Well, the PET you can perform if you want to see the bones, a PET with fluorine, or if you prefer to see the inflammation, you can perform a PET with FDG. With the PET of FDG, you can detect easier the areas of inflammatory disease in the articular areas.
Can NAF add anything? Can NAF add anything, NAF PET?
Our rheumatologists are asking for more and more PETs of this, not very often of course, but sometimes yes, when they have discordances with the clinical symptoms or so on. And we have detect areas of increased activity in more osteoarticular areas than they expect. It seems that the sensitivity can be quite good, but it's, of course it's not a routine exploration in a still disease.
Thank you.
Hello. I have a question for Dr. Roca. You have any experience with using chloral hydrate in pediatric patients? We know that the chloral hydrate interfere with the FDG uptake, especially when the anesthesia or anesthetic is not available, especially in the after 45 minutes or 55 minutes of injection of FDG.
Chloral hydrate is, if I am well informed, in small children, in babies, and in babies we don't need any sedation because we can use the relaxed after the milk. But in any case, we don't like to perform sedation or anesthesia in our children, and for this reason we ask the pediatric radiology department of our hospital to come to our department when the anesthesia is required. But we don't administer ourselves chloride hydrate. And in babies under 12 months, we never administer sedation.
Okay, thank you both for your nice lectures. For Dr. Tam, you mentioned that we can use NAV without CT instead of bone scan. If we have the luxury to choose between both, what do you think? Which is better, the NAV or the MDP bone scan?
Well, the message I tried to convey was that for many indications we're not quite sure yet. If you can choose, if you have it available, you can do the sodium fluoride. It will give you excellent images. Those will be similar.
In benign and malignant?
Yes, in benign and malignant. If you don't have it, if you have limited availability, one indication I would use it is in non-accidental trauma.
Thank you.
Thank you very much for your lectures. I just want to ask Dr. Isabella, you mentioned about CT for attenuation. Do you really find the CT for attenuation correction in children is really useful, or only for anatomic localization? Thank you.
Well, for anatomy, you need a diagnostic low-dose CT. But if you have, for example, one case of neuroblastoma or osteosarcoma, and you have a whole body performed the day before, a whole body MRI, then you can diminish the dose of the PET-CT, having an acquisition of the CT with a very, very low dose CT, like 2 millisieverts, and with a very bad image of the CT, not for anatomic localization, but yes, useful for attenuation correction. It's not very often.
Professor Tim, you just briefly came across oral administration of FDG, if I'm not mistaken.
Sodium fluoride.
Okay. Thank you.
Sorry.
So we conclude our session. Thank you very much.